Welcome everybody, Provost, distinguished guests, faculty of health science staff and students. Welcome to the inaugural lecture of Professor Juliette Hussey. I'm particularly gratified to welcome Juliette's family, her husband Gary, who is still waiting for a taxi, I think. He's on the way. Hopefully he's watching online. Her sons Gavin and Robin, along with his wife Nora Marie, who've recently arrived back from Australia, and they're expecting Juliette's first grandchild this year, if I can put it that way, Nora. It's her night, after all. I'd like to also welcome Juliette's father, Paul, and her brother, Michael, who are joining us online. The inaugural lecture series provides the newly appointed professors with the opportunity to showcase their academic activity to the college community, their close friends and family, and to the public. An inaugural lecture is a significant event in the academic staff members' career at Trinity College. Inaugural lectures are ceremonial occasions, which is why we're all dressed up like twits. Professor Hussey is from Dublin, qualified in physiotherapy from University College Dublin, and spent 8 years working clinically at the Mater Hospital in Dublin and Great Ormond Street Children's Hospital in London. While working in Great Ormond Street, she completed a master's in King's College. She came to Trinity College in 1992 as an assistant professor in physiotherapy. In 2001, along with Professor John Gormley, Professor Chris Bell and Professor Ian Graham, she developed a master's programme in cardiac rehabilitation, which started in 2002. And I want to draw particular attention to John and Chris, who have been an enormous influence and mentors for Juliette throughout her career. She was promoted to Associate Professor in 2006, awarded her PhD from Trinity in 2007, which investigated the interrelationship between physical activity, fitness and body composition in children. She was then promoted to Professor in Physiotherapy in 2015 and was successful in obtaining a personal chair in 2022. She was the head of the discipline of physiotherapy from 2003 to 2014, led on developing the undergraduate programs in physiotherapy and allied health sciences delivered in Singapore. These one-year programs were the first to be developed in universities overseas and were at the frontier of Trinity's global engagement strategy. Juliette was elected to Fellowship of Trinity in 2011 and appointed as Vice President for Global Relations for 2 terms from 2014 to 2021. During that time, she delivered an ambitious global relations strategy, developed a number of highly successful reputational partnerships with leading universities globally, including the dual degree with Columbia University in New York. Professor Hussey currently leads a group working in the area of exercise rehabilitation in patients with cancer. Most of this research is in conjunction with colleagues in St James's, and in particular, another important mentor in Juliette's career has been the head of surgery here in Trinity, Professor John Reynolds, who's with us tonight. Her research is translated and aimed at scientifically improving exercise prescription to optimise therapeutic response. She has supervised 31 postgraduate students to successful completion, including 9 PhDs, and is currently supervising 3 masters, 2 PhD students. And Professor Hussey has over 110 full paper publications in the scientific literature. She's a member of the board of St James's Hospital here and sits on the Quality and Safety and Risk Committee, and she leads the survivorship research team in Trinity St James's Cancer Institute and sits on the senior council of the Irish Association of Cancer Research. Oh. I mean, really, that's just an incredible amount of work. Anyway, I want to finish with a few tributes from colleagues. I won't name them. You might be able to guess. Professionally, Juliette has been at the forefront of demonstrating the benefits of exercise in health and disease, not least in cancer survivorship. For this, she has rightly gained a national and international reputation. She's also been a fantastic ambassador for Trinity in her capacity of VP of Global Relations. Juliette is very loyal, shows professionalism in everything she does, and is always inclusive. She's highly respected for her mentorship of junior trainees. Juliette's the most successful researcher in the discipline of physiotherapy. If you're a successful researcher, it's often thought that you won't have any time for students. Juliette is the complete opposite. She is also the most student-centred person in the discipline. Whether as head of discipline, lecturer, professor, or college tutor, she has always put the student first and acted as their advocate. There are many physiotherapists and others working today who were helped through their studies in times of need and difficulty by Juliette. Now, the last 2 divergent stories, you're going to have to guess who said this, but I don't know who knows you best. Juliette's always been very forward-thinking. When I was a student here in physio in the late 90s, Juliette was using video within her lectures to highlight paediatric reflexes in developmental stages, while most other lecturers were using acetates or blackboard and chalk. Versus The biggest compliment of the night is a reference to Juliette's legendary IT skills. She's completely useless. We're lucky that her inaugural lecture is on PowerPoint and not on written acetates. Needless to say, I didn't inquire how those conclusions were reached. Apart from being a devoted family person, Juliette's also a dog lover, 2 very mischievous pooches, hopefully a photo later, and a great exponent of the early morning sea swim. Now, before I finish, I'd like to remind everyone that only after their inaugural lecture are the professors spared the searing critique of the audience. I mean this, no Joe. Is Joe Keane here? No questions. Juliette is allowed to leave the podium without answering a question. And I invite everybody to join us for refreshments after the lecture. And I have 1 or 2 more words to say at the end. So without further ado, ladies and gentlemen, I give you Professor Juliette Hussey and her inaugural lecture, Challenging Stasis.
Thanks very much, Professor Doherty, for that lovely introduction, and thank you all for being here. It's really wonderful to see so many family, friends, colleagues. Provost, thank you so much, and past Provost. It's really important having both of you here. So Colin's said quite a few things I can probably shorten it now because I think you've sort of told them a few things, but I'll start at the beginning, and the other person I want to deeply welcome is my father, who's watching online. Hopefully the IT is a bit better than my skills, and Kevin is way beyond me in that, so hopefully that's working well. So I'll start at the beginning, and I was born in Vietnam, in Saigon, and lived there for the first 1.5 years of my life. My parents were living there at the time, but with a new baby and the war intensifying, the activity moving further south, they felt it was time to leave Vietnam. And we moved to Dublin, where my next 3 siblings were born, and lived there until I was 11. And we then moved to Brussels, where the family of 6 became a family of 7, and my younger brother, Michael, was born in Brussels. Both my parents were keen that I would come back to Ireland to go to university and to receive an Irish education. And my aunt, Caroline Hussey, who may be known to many of you, was particularly keen that I would go to UCD. Caroline was an academic in UCD. I'm honoured to stand here in her gown. She is also a graduate she did her PhD also in Trinity. And here she is at a reception in her position as registrar, officiating at a ceremony to mark the 50 years since graduation, giving her elder brother, my father, his 50 years since he graduated certificate. So I returned, as I said, came to UCD, and that was in Earlsfort Terrace at the time because the medical faculty had not moved out to Belfield. I think it's just important to put a little bit of historical context of what physiotherapy was like at that stage. It wasn't a degree profession. It became a degree, I think, in the late 80s, and that started in the UK and Ireland. So it was a diploma. There was very little research going on in physiotherapy. But what was happening in the whole area was research was starting in the whole area of exercise and the prevention of disease. And I don't know, some of you may have heard of Jeremy Morris and the London bus transport study. He observed in the 60s and 70s that bus conductors had much lower levels of heart disease than bus drivers. The bus drivers had also almost twice the incidence of heart disease, and they were similar in every other way apart from being active during their daily job. And it led to observations of the protective element of daily physical activity and compared to people being in sedentary positions. And Jeremy Morris himself lived until 99 and a half, so he was he probably must be a proponent of what he preached. And then in the 80s, Stephen Blair and Ralph Pfaffenberger, they did a lot of work really solidifying the cause and effect in terms of how exercise can prevent premature mortality and particularly delay cardiovascular disease. And so the research in this area was really growing. And the way I saw it was that physiotherapy had a huge part of implementing this at a patient level. These are epidemiological studies, and the challenge was how we could put that into practice. I worked clinically, as Professor Doherty said, for 8 years, and I think that would not be the norm now in terms of a young, somebody with an aspiring academic career would probably want to get their PhD done quickly and to get postdocs, get papers, and get into academia. It was very different. And I really valued the time I had working clinically. I think it gave me a very good idea of multidisciplinary working, comprehensive patient care, but also gave me the ideas of many of the questions that I endeavoured to answer later on. So I worked in the Mater for 4 years, and that was the National Cardiothoracic Surgical Unit, so we were very busy, particularly in the intensive care, working in respiratory care, post-operative. Patients had a lot of post-operative atelectasis. There was a real focus on early extubation, early mobilisation for the cardiac surgery patients. So the idea of cardiac rehabilitation was starting. They had quite an intensive programme. It wasn't called ERAS, early recovery after surgery, but that's what it was, a very strict programme in terms of moving people very quickly to early mobilisation, walking on the stairs, and a walking programme on discharge after about 7 to 10 days. At that time, there was also many other patients in the intensive care units, and patients following thoracic resection for esophageal cancer or lung cancer. They often had a very different and a much slower progress, and many of these patients were probably diagnosed later than they would be now, had lost significant body mass. And I just remember how the whole focus was trying to get them self-ventilating out of the intensive care. And we rarely thought of past that. There were no formal exercise programs. And I was actually thinking this morning when I was walking those two pooches, how I remember actually one of the people I worked with in the Mater really saying, why aren't we doing this for the patients after cancer surgery, the way we're looking after people after revascularization of the heart? So I then went, after 4 years, I went to work in Great Ormond Street in the acute thoracic unit there, and there was a lot of focus on corrective congenital cardiac surgery, heart-lung transplantation, and it was a very large cystic fibrosis unit. And what we were starting to see in cystic fibrosis was that patients were being treated more comprehensively with exercise, not just to promote mucociliary clearance, but also for all the other health benefits in terms of bone density and maintaining muscle mass. And when I was there, I was successful in getting a research position, and I was supported to do my master's in King's at that time. So I came back to Trinity armed with my master's to an assistant professor position, and if you starting off the first building and working your way around, we were in these prefabs to begin with, and then progressively worked around to where we are now, which is a wonderful building. Came to a department with very small pockets of research, no research facilities, but a very supportive head of department, Mr. Peter Young, and a dean, the late Davis Coakley, who really had such a vision in terms of the allied health sciences. And when the plans for the building were taking shape, we really encouraged Professor Coakley that he would include a room for an exercise laboratory, which is actually just 2 doors down in the plans. And that was really a huge help to get us starting in terms of education and research and exercise testing. So it was just a room. There was no equipment, but that was a good start. And then 2 years later, 2 very important people arrived in Trinity, and without whom I certainly wouldn't be here today. Professor John Gormley came to join the discipline of physiotherapy. He had his PhD and was ready to supervise others. And then Professor Chris Bell, who's the chair in physiology with a strong background in cardiovascular physiology. He worked very closely with myself and John, allowed us to take modules on the MSc in exercise physiology, and really helped us gain expertise in the cardiovascular measurement associated with human performance and exercise testing. And so then, thankfully, John and Chris supervised my PhD. which was in the broad area of exercise, looking at activity levels in children and how they were related to both fitness and activity. And the first study gained quite a lot of media attention because we were the first to demonstrate that even in children as young as these children were 7 to 9 years, there was already a difference in the amount of vigorous physical activity between boys and girls. And we also, I think importantly, validated a measure of physical activity that we were then able to use in other studies. And just in terms of defending my IT skills, in those days, to actually download each one of those files, I had to save it onto a floppy disk. There was 150 different floppy disks because it could only get one. And I have to defend some of my IT skills that I actually managed to get through. And so then got my PhD, a great celebration with the family. And just for my sister, the there was at the graduation, the honorary graduates were having their graduation as well, and there was a Hollywood star who was the guest of one of the honorary graduates that my sister managed to spot and identify. I can't even remember his name now, but if any of you recognise him, my sister will know. So in tandem with doing the PhD, both John and I worked very closely with Professor Bell, but also the cardiologists in Tala, Professor Ian Graham and Dr. Vinnie Marr, in developing an MSc in cardiac rehabilitation and prevention. And this was really significant in terms of the number of people that came through that programme and were then able to devise and develop and evaluate their own programmes, both here in Ireland and further afield. And there was a real focus. It was the time of the launch of the cardiovascular health strategy, which identified that patients who were being treated from a cardiac point of view should have access to cardiac rehabilitation. So this helped to build our research activity. Most importantly, it provided funding to allow us to equip that very nice room that Professor Coakley had arranged for us. So we were able to start buying equipment that we could then use in terms of research for testing. And a lot of that was bought from the funds generated. We were also successful in getting some other grants, but it really spearheaded that. I think at this stage what's important to say, I had my PhD, we were starting to build a programme, but it was really important that programme expanded to other people in the discipline, and we really needed to build capacity because it was very small numbers of people doing research. And so I'm just going to put a few slides of some of the PhD students. Julie Broderick being my first PhD student, who many of you will know. She's our excellent head of discipline at the moment. And Julie had a very successful clinical career and then got a HRB fellowship, which allowed her to do a PhD full-time. And we started working in the area of cancer. And one of the things that was really interesting was we used that objective measure of physical activity that we'd validated earlier on. And we found that activity levels were very low, despite patients being scored as actually being functioning well, doing everything that they normally did. And it really led us to think of this paradigm shift that people can be very functional by being very sedentary. And in order to prevent those negative effects and improve overall health, we needed to use this time at diagnosis to really institute much more positive health behaviours. And one of the studies that Julie did identified that patients in the year after breast cancer lost lean body mass, continued to put on weight, and that formed the sort of basis of Emer Guinan's work, where she looked at sort of targeting metabolic risk in patients after breast cancer. And then Gráinne Shields, Linda and Jenny, I'm going to talk about their work when I talk about the specific esophageal programme. And Gráinne Shields, who's a clinical specialist in St. James's now, worked between myself and Stephen Finn in histopathology and David Heavey in psychology, examining exercise in patients following prostate cancer. I think the other important thing to say in this, in terms of also not just building capacity, it was also building really good collaborations with other departments, and many of those have continued to flourish. And that was really important in developing those strong links. And then Emer Barrett and Cushla Ford within the area of health promotion and paediatrics, again developing their own areas in these really important fields. Before I go into the story on the esophageal cancer research, I just want to acknowledge the opening of the clinical research facility. That was a game changer for us. There's no way we could do the types of studies that we have done without the clinical research facility in St. James's. To really acknowledge the people who were at the forefront of planning that in many it's 10 years later, and the amount of work that's come through would never have happened without it. So I'll talk now about the programme, particularly with Professor Reynolds and colleagues in the Department of Surgery. When we started talking about this in this area, I was reminiscing to Professor Reynolds how really, when I was treating these patients, there was very low expectations, and patients often took a long time, and we really didn't think of any formal rehabilitation. And around the same time, I remember a student was giving me feedback after a clinical placement, and she told me how one of her patients who had thoracic surgery for a lung resection had no access to formal rehabilitation and ended up having to go to pulmonary rehabilitation, which was not the ideal, but it started me to think we really need to be doing more for these patients. But we didn't know enough about how they were to actually start a programme. And that's, if you like, the research that we commenced then. So I really want to acknowledge you, John, for all the work. And, in the last 8-10 years, we've brought in an awful lot of grant income. I think this is probably at about 70 or 75 at this stage in terms of full papers. What's really important is more than 350 patients have gone through clinical trials in this area. And yesterday, or the day before, when I was working with Linda, we were doing another preparation. I said, let's just see actually how many patient visits that was. And Linda, I think it was over 1,500, wasn't it? So a huge amount of activity has actually taken place in this area. Now I want to acknowledge Niamh Murphy, who was the head of physiotherapy in St. James's and was really keen to collaborate. And she had an excellent senior physiotherapist, Ciara Feeney, who worked in the intensive care unit, and said, we'll start doing some research. And we decided just to look at people who are going for esophagectomy and look at a number of parameters and see, is there anything that we could target preoperatively? And the only thing we found that was different in patients, between patients who did develop a post-operative pulmonary complication and those who didn't, was that those who didn't were doing much higher levels of physical activity in the week before surgery. Some of you might say that's, well, is that a big finding? If they were doing more, they were probably fitter. But it did allow us to think, well, this is something maybe we can start putting in place to improve them in that period of time. So then we decided, well, we need to understand actually how patients are after esophagectomy. And Jenny Gannon did some really nice work where we looked at patients, compared them to healthy matched controls 16 to 18 months after their esophagectomy. And we found the incremental shuttle walk test is a test of fitness. We found that the patients after cancer were much lower in fitness, and they were doing much less moderate and vigorous intensity activity 6 to 18 months after surgery. So then we said, well, okay, what happens around that time of surgery? So on the left, we looked at patients at time 0, which was when they were diagnosed about to have surgery, at 1 month after surgery, and 6 months after surgery. And we found that their fitness did improve, did get back to what it was before surgery. Mind you, that was probably much lower than normal. But their activity levels, the amount of time in sedentary and the amount of time in vigorous activity stayed low. So there was a real need to start to do something in that rehabilitation period. We also looked at what happens when patients have neoadjuvant treatment. Many of the patients before esophageal resection will have chemotherapy before they have their operation. And we found in that period of time that they dropped their lean body mass and that was associated with the drop in hand grip strength. And hand grip strength is a very good composite measure for, if you like, for your overall strength. So we were really building up, if you like, the story and understanding how these patients present, after the operation. And we also decided, well, we'll ask them how they feel. And this, what does survivorship mean? And I think these comments from patients told us a lot. There was the first one, there was days I'd do nothing. I'd just walk and sit in the chair, and walk back to the chair. The fatigue that they spoke about. And they also talked about how many of their families and friends told them to sit down and take it easy. They'd been through a lot, which is often, not what we were trying to encourage, but totally, completely understandable. So we were building the picture. We could identify, right, these are the challenges that people with esophageal cancer have in survivorship. They've nutritional problems, they've weight loss, they've physical dysfunction, and they've other issues like in terms of reoccurrence. And so what we did was we put together a program that we identified we called Restore. And Restore involves supervised exercise sessions, home-based exercise sessions, one-to-one dietary advice, and group exercise sessions. And we said, let's do this over 12 weeks with an increasing amount of time that the patient would spend in home exercise. And we put this together, we applied for funding, and we got funding from the Health Research Board to investigate this. And that was in 2014. The then Minister of Health made the award, there was a celebration for people who got the awards. And this is what we did. We found that this Restore programme, it was feasible. We found that we had a reasonably good recruitment rate, and that was with quite strict entry criteria. Patients adhered to the supervised exercise, and there was no adverse events. And this was only a single-arm small study, but we could see already that there was an improvement in their fitness in this, in terms of efficacy. So we went further. We did a randomized controlled trial. There was 22 in each arm. And we found that there was a significant increase in cardiorespiratory fitness in the intervention arm, so that they improved their fitness. We were somewhat concerned about finding differences in quality of life with some of the scales we used. And so we asked the patients actually how they found the programme. And I think this was very encouraging when we could see that it got them back, it gave them the impetus, it gave them confidence, it gave them, they were starting to become included, they got the phone call, they got confidence to do more. And it made us realise the importance in terms of actually changing an approach to activity, really as part of this overall programme was an ideal way of rehabilitation. So with the Restore programme, because it was successful, we then went for further funding in 2019 for a health research, a definitive intervention. We were successful in getting that in 2019, and that was the time of GDPR, so we were a bit delayed in getting everything through ethics. We finally got everything through ethics, all the paperwork signed and finished in March 2020, which was so the study that was just ready to open couldn't recruit. And after a number of weeks and months of getting worried, and the number of people that were, what were we going to do? We decided, well, let's see, could we actually deliver this virtually? Was there a way of delivering it through telerehabilitation? The patients were there, they needed the rehabilitation. It was an ideal time to try this. And we worked with an Irish company that have a very good online platform where we could actually we could see their heart rate. So the patients, even being at home, we were able to identify how hard they needed to exercise and slow things down if their heart rate was too high. So we were able to manage to monitor them. And it was very successful, and Louise, who's here, then presented this at ASCO, the American Society of Clinical Oncology, who were really interested in they had a session where they were really looking at equity of access to rehabilitation. And this was really a way of actually showing we can actually offer it much wider to people if we actually use tele-rehabilitation. And it also then got us to think we could use it in other ways. So now, in terms of the Restore programme, the one that finally started in 22, and should be finished in the next few months, we offer patient participants the opportunity to do some of that virtually. I would have never thought that after getting those grants that I would be in 24 with still not being able to present the results. But such was COVID. I think you could probably ask at this stage why we're only doing things after surgery, because I showed you earlier that people they lose lean body mass, they lose fitness. This study actually showed that the impact of chemotherapy, there was a drop of 2.4 mils per kilo in terms of fitness. That might seem like a very small amount, but if you're borderline in terms of your ability to withstand the demands of surgery, that can make a difference. And so we decided to look, we decided what we would do is look at actually can we improve people's performance before surgery, make them more fit for surgery. Now, one of the issues in terms of particularly thoracic surgery is you have to do that within, a person has to have surgery within 30 days of diagnosis. So that gives you very little time in terms of kind of normal, moderate intensity exercise programs. To see an increase in fitness probably takes about 6 weeks, 8 weeks to see changes. But some of you may be familiar with interval training, where you do all-out exercise at peak work capacity interspersed with lower levels, and that can derive benefits in as short as 2 weeks. So we got funding to do the high-intensity training preoperatively, pre-HIT program. The patients can do that either at home or in the clinical research facility. Many people would say that would never work. How would patients ever be able to do that? It won't be acceptable. Emily, who is here, where's Emily? Emily's there, has demonstrated it is acceptable and feasible for patients, and we look forward to the full results of the study. And then I suppose finally, in terms of the esophageal cancer research, part of a network grant, the AllCan, which is funded through Breakthrough Cancer, led by Jacinta O'Sullivan, and along with myself and Helen Coleman in Queen's. And this has brought a network of people from all over the island in esophageal cancer and Barrett's esophagus together. And the area I lead is really to identify how can we improve physical and mental health in patients with both Barrett's esophagus and esophageal cancer. And so 30 years later, I think you can safely say it's a very different department than the department I came to. Just before I finish, I just want to circle back to that MSc, which was obviously very good in its own way. But one of the other things we did was we looked for a health research board, for an Irish Aid grant, which was administered through the Health Research Board. And we brought that to Vietnam. I went there twice and did intensive teaching over 2 periods of time in Vietnam. That was very important in itself, in that we had built some good relationships. Myself and Emer Barrett spent some time over in Vietnam. And it was very important in itself, but it also had benefit later on when, 2 years later, we were approached by what was then the International Office in Trinity about considering that to see if we would do 1-year programs with recognition for prior learning for people who had diplomas in physiotherapy, in occupational therapy, in diagnostic radiography, and bring them to degree level. And so, encouraged by the then Vice Provost, who then became the Provost, I went, and we were very successful. We didn't know at the time we were so there was 3 other universities looking for this. And one of the things that actually made them choose us was the fact that we had that experience in Vietnam, and that they felt that we were prepared to go and work there. So that was a huge program. Probably the biggest project I've ever done to date. Only overtaken by the one that Professor Gormley led when he actually brought it a whole stage further to a joint degree in physiotherapy with Singapore Institute of Technology. And both myself and John were actually out about a week ago with the person who he was the president of SIT. He's now a government advisor, and he, it was really comforting to say, to hear him talk about how the relationship with Trinity was the most positive of all the relationships. They've got 11 very close relationships with other universities, so I think that was a very positive feedback from him. And then that, of course, led me, I think, probably one of the reasons why I ended up in global relations, and I think that was spent 7 years there, which was very successful, exhausting, but successful, where I think we achieved a lot. And some of Colin talked about the joint degree and the dual degree with Columbia, but we also started the first foundation programme in a partner of Trinity. And just before I left, we were ranked 8th in the world in terms of internationalisation, so that wasn't too bad. These are just, before I finish, some of the times we had in global relations, and I got to meet lots of really interesting people, but most importantly, worked with a really fabulous team led by Fidelma McNamara. So I just want to finish now and sort of say, what's the future in terms of the work I'm going to be doing? Working closely with Rachel Keating and Michael Capra and Sarah Curry and Cheryl Alkin in Crumlin to look to see there's a huge need for further work in terms of the physical needs of children and adolescents after cancer. Another very interesting study I've managed to be part of, and Professor Montelares, thank you very much for my inclusion. I think we need to, and when Stasis first came to me about this, new therapies, cell therapies, I thought, oh, this is not me at all. But, understanding there's going to be more and more different treatments over the years. We need to understand what are the impact, the physical impact it has, and how we even try and prevent those, address them. But we need to start that work now, and it's a great privilege to be part of that group looking at cell therapies. And I think we badly need to look at how we incorporate both cardiac and cancer rehabilitation. They've many of the same risk factors, very cardiotoxic drugs, and so many of the patients that will survive cancer will go on to have cardiovascular disease. So I think it's something that the two rehabilitation areas have grown in parallel, and I think we need to look at them much more closely together. And I'm doing some work in terms of developing rehabilitation in Oman and with a PhD student, and some early work in Zambia. So that is I hope I've demonstrated in this period, this lecture, an overview of the work that I and colleagues have been doing, and just want to acknowledge the PhD students, research colleagues, funders, general colleagues, a fabulous research team that are just second to none. And most importantly, my family, my husband, my boys, my daughter-in-law, my sisters and brothers, my dad, and the Sunday Walkers, and the wider Hussey, Truick and McGrath families. Thank you. Not bad in time.
You can say it, I'm not going to ask questions. Well, thank you. That was a tour de force, Juliette. Thank you for that. It was an amazing amount of work, and the interdisciplinarity of it all was just incredible. And you were doing that one time when that word wasn't even coined. So the good news is you don't have to take any questions. But we've got one final thing to do. I think the physiotherapy department wanted to make a little presentation to you. So this is just a little gift from the department, just in honour of your inaugural lecture.
Thank you so much.
So I invite you all to join us for reception out in the front, and thank you, and we'll see you at the next gig. When is that? When is the next one? I don't know. Okay, thank you very much, everyone.